Assalamu alaikum. Now I would like to discuss about small bowel obstruction versus ileus. In small bowel obstruction, you will get nausea, vomiting. Like in ileus, you also get nausea, vomiting, abdominal, acute abdomen, obstipation. This is common. But in small bowel obstruction, there is hyperactive or absent bowels. There is in small bowel there is hyperactive or absent. But in ileus you may get decrease or absent bowel sound. When you do X-ray, what you will find in small bowel obstruction, you will get air fluid level, dilated proximal colon or dilated proximal bowel, collapsed distal bowel. But in ileus there is no transition point, but in small bowel obstruction there is transition point. There is dilated loops of bowel in ileus, but in small bowel obstruction there is also dilated loops of bowel, proximal bowel, but their distal bowel is collapsed, little or no air in the colon or rectum. So small bowel obstruction can happen prior surgery, weeks to years. But ileus happen in recent surgery hours to days. Metabolic cause can cause ileus like hypokalemia and medication induced. In small bowel obstruction there is distension and increased bowel sound. And in ileus there is also possible distension and reduced or absent bowel sound. Reduced or absent bowel sound. And in small bowel obstruction, small bowel is dilated. In ileus also small bowel is dilated, but in ileus large bowel is also dilated. But in small bowel obstruction, it's very simple that large bowel is not dilated. Ileus is a functional defect in bowel motility without an associated physical obstruction. Nausea, vomiting, abdominal pain may happen, obstipation may cause. That means failure of the flatus to pass or failure of there is hypoactive bowel sound. There is persistence of signs and symptoms. 3 to 5 days postoperative is termed as prolonged pathologic postoperative ileus. Ileus is most commonly complication of abdominal surgery but can be seen in other conditions like retroperitoneal or abdominal hemorrhage. Ileus may be seen in intra-abdominal inflammation like pancreatitis, intestinal ischemia, and electrolyte imbalance may cause these ileus. The risk factors include surgical complication, ureteral injury, bowel manipulation, laparotomy, longer surgery duration due to increased intra-abdominal inflammation, and elevated sympathetic nervous system tone. Postoperative opioid analgesic techniques to prevent PPI include epidural anesthesia, minimally invasive surgery, judicious perioperative fluid of intravenous fluid, minimize gastrointestinal edema. Diagnosis is clinical, although abdominal X-rays revealing dilated loops of bowel with no transition point. Dilated loops of bowel with no transition point. Uh, Postoperative ileus typically self-resolves as bowel motility, gradually returns and therefore are present conservatively managed. Antiemetic bowel rest. Urgent surgical exploration is indicated in patients with acute abdomen. It is not indicated for postoperative ileus unless there are changes between serial examination. However, mechanical bowel obstruction typically causes hyperactive bowel sound. Postoperative mechanical bowel obstruction may have temporary return of bowel function prior to symptom onset. Unlike postpartum ileus, compared to post-operative ileus (API), X-ray in the mechanical X-rays in mechanical bowel obstruction are more likely to reveal air fluid level and a clear transition point. Abdominal X-ray commonly reveals dilated loops of small bowel and air fluid level. In here there is dilated loops. This is dilated loops with transition point. This is the transition point. And in here dilated loops without any transition point in postoperative ileus (PPI). In mechanical bowel obstruction, managed initially conservative maneuver. Those with evidence of complication like fever and hemodynamic instability, urgent surgical exploration should be done. So these two things, small bowel obstruction and postoperative or ileus. In small bowel obstruction, small bowel is obstructed, large bowel is not obstructed. In paralytic ileus, large bowel, small bowel, both are obstructed. In If you do X-ray in small bowel obstruction, there is dilated loops of bowel with air fluid level, but in ileus there is a dilated loop without any transition point on no air fluid level in here. In here, small bowel, large bowel, both are obstructed. These two should be thought. In paralytic ileus, there is gastric dilation, gas field of the large intestine, gas field in the large intestine, and the gas field looks in the small. This is small intestine. This is large intestine. Gas will loop in the large gastric dilatation. Gas will loop in the small. Look at the picture. Try to remember these very few things because understanding things will make your memory to keep longer. If you don't understand anything, if you're just trying to cram everything, that means you will unable to remember these things. This is gastric dilatation, this is dilatation of the large bowel, this is dilatation of the small bowel. Another important topic is gallstone ileus result in small bowel obstruction due to these gallstone. These gallstone causes obstruction that has not passed through the biliary enteric fistula. As the stone advances, it may cause stumbling, obstructive pain. It may cause stumbling, obstructive pain. Treatment involves surgical removal of the stone and cholecystectomy. Another Oh, very high topic. Ogilvy syndrome or acute colonic pseudo-obstruction. In acute colonic pseudo-obstruction, that means Ogilvy syndrome. Ogilvy syndrome. mm, in here, there are major surgery, traumatic injury, severe infection. Major surgery, traumatic injury, severe infection. If electrolyte derangement, low potassium, magnesium, and calcium, low potassium, magnesium, and calcium, there may be medication, opioid, and anticholinergic, and neurological disorder like dementia, stroke, MS, and Parkinson's. Major surgery, traumatic injury, severe infection, major surgery, traumatic injury, severe infection. There is electrolyte derangement, low potassium, low magnesium, and low calcium, and medication, opioid, and anticholinergic. And the neurologic disorder like dementia, stroke, MS, and Parkinsonism. Abdominal pain, abdominal distension, obstipation, vomiting. Tympanic to percussion, decreased bowel sound. Tympanic to percussion, decreased bowel sound. If perforation, guarding, rigidity, and rebound tenderness. If perforation, guarding, rigidity, and rebound tenderness. Imaging X-ray in X-ray colonic dilatation, normal hostra, and non-dilated small bowel. Colonic dilatation, normal hostra, and non-dilated small bowel. CT scan is colonic dilatation with normal obstruction. CT scan colonic dilatation. And NPO, NG suction, rectal tube decompression. New treatment can be given in Ogilvy syndrome if improvement not occur within 48 hours or if the cecal diameter on imaging exceeds 12 centimeter, the new treatment should be given. Common causes include Ogilvy syndrome is hypokalemia, hypomagnesemia that lead to autonomic disruption of the colon, major surgery, and neurologic disease. Anticholinergic medication. Gastric bowel obstruction caused by the mechanical obstruction leading to postprandial pain and vomiting. There may be gastric malignancy, pancreatic adenocarcinoma. What are the common cause of gastric outlet obstruction? It may be gastric cancer. It may be pancreatic cancer with gastric and duodenal invasion. This is the most common cause, pancreatic adenocarcinoma. Invades into the gastric and the duodenal side. Peptic ulcer disease, Crohn's disease, and structured pyrolytic stenosis. Secondary ingestion of the caustic agent. Secondary ingestion of the caustic agent. Gastric polyps and gastric bizarres. You will get this succussion slash abdominal succussion slash, which is elicited by placing a stethoscope over the upper abdomen and rocking the patient back and forth. Physical examination may show succussion splash, which is elicited by placing stethoscope over the upper abdomen. Written gastric materials more than 3 hours after a meal will generate a splash sound. Written gastric material more than 3 hours will cause a succussion splash. Acid ingestion can cause fibrosis 6 to 12 weeks after the ingestion. Uh, 6 to 12 weeks after the resolution of the acute injury. Upper endoscopy to confirm the diagnosis and treatment is usually surgical. Gastric bizarre results in accumulation of the undigested, like hair, foreign objects. If you somebody accumulates hair, foreign substance into the stomach, bizarres can cause gastric outlet obstruction. Very rare. Most patients underlying motility disorder, gastroparesis or gastric surgery, diabetic gastroparesis occur who have diabetes for longer duration. Postprandial bloating, nausea, always satiety may happen. A nuclear gastric emptying can diagnose gastroparesis. Ascaris recent travel from the endemic region, Asia, Africa, South America. There may be pulmonary or intestinal problem. Manifestation complications include obstruction of the small bowel or hepatobiliary tree, cholangitis, pancreatitis, treatment in albendazole or mebendazole. Albendazole or mebendazole. And that's all about these. Hope you enjoy.